This is Michael Smith of MedPage Today. I'm here in Washington at the joint meeting ICAAC-IDSA. I'm speaking with Dr. Andreas Diacon of the University of Stellenbosch in South Africa. For many years, the armamentarium against TB has been static. There have been no new drugs. At this meeting, some new drugs are being presented, and Dr. Diacon is presenting data on what is perhaps the most advanced of those new drugs. Can you explain, Dr. Diacon, what this drug is? What is it called? What does it do?
The new drug I was having my presentation about today is called TMC-207, and its mechanism of action is that it blocks ATP synthase in Mycobacterium tuberculosis.
I see. So, in other words, it prevents the bacterium from having its energy, as it were.
Yes, one could say that the mycobacteria, the more active they are, the more disease they're probably able to cause. And that bacterium or that antibiotic is able to slow that process down and eventually kill the bacteria so that the people can be cured.
I see. You're presenting data today on the first phase of a study. What were you looking at? What did you find?
We tested that substance added to a conventional regimen in patients that have drug-resistant tuberculosis. And the data I was presenting are preliminary because it's only the first quarter of the study that has been completed. And the results were presented because some safety analysis and some analysis into the drug levels in the blood were planned up front to be analyzed after 50 patients, which was not done. A surprise to us was how well the drug actually worked on the disease. We could see that there were a great lot more patients culture negative at 8 weeks than with the new drug than was the case with placebo. Okay, so you had and you were able to show actually an efficacy difference, which was, I think, quite dramatic. It was sort of in below 10% versus nearly 50% were able to kick the bacterium. What about the safety analysis and the tolerability? How was that? The safety analysis and tolerability was very good on that set of patients that does not yet fulfill the criteria of being a full study. So the study cannot yet be stopped just because we have a very promising result. It needs to be completed first so that we have the complete safety analysis, tolerability, and hopefully also very promising efficacy results then after the full set. I see. Obviously then the clinical implications are wait and see. The clinical implications are be hopeful and wait and see. I see. Well, thank you very much for your time, Dr. Diacon. I'm Michael Smith, MedPage Today.